All right, so we can go ahead and begin. So hello everyone, welcome to today's session. Today we have Dr. Amrit Hansra, I hope I'm pronouncing that right, and he is a vascular and interventional radiologist. So thank you so much for joining us today and welcome.
Thank you guys for having me. I really appreciate it. Like you mentioned, yeah, I'm a vascular and interventional radiologist. It is not the most well-known career in medicine, and that's one of the reasons that I like talking about it, because I like to spread the knowledge and pay it forward, because I really wasn't aware of what it was in the beginning. I didn't go into medical school knowing I wanted to be an interventional radiologist. I actually didn't even know what a diagnostic radiologist really entailed. And I had great mentors throughout the way, which I'll be talking about a little bit in this talk. And they really helped me figure out which way I really wanted to go and really bring that out in me. So feel free to ask any questions. I know I'll see them. I should see them pop up here in the chat, and then I can answer them along the way. Happy to. It looks like I'm just learning all this right now. There we go. Okay, so good. Some questions already come, and I will answer them throughout. All right. So I think you guys probably can see that too. So let's minimize that. There we go. So what is interventional radiology? The fancy way of saying it is specializing in minimally invasive procedures utilizing the latest advancements in medical imaging and providing unparalleled precision. So what does that really mean? Basically, that means I have started off as a diagnostic radiologist. So I read CT scans, MRIs, X-rays, ultrasounds. I interpret all the images. But not only do I do that, I also provide minimally invasive interventions using those modalities as well. And what does that mean? Right, there we go. Most interventions are performed through a pinhole. So there are no open surgical procedures here. Everything is through, most things, I would say 98% of the procedures I do are literally through the size of a pinhole, through tiny catheters, tiny wires, even micro catheters and micro wires. And what does that mean for patients? Quick recovery time. Whether it's trauma, whether it's cancer therapy, fibroids, you name it, it is quick recovery time. Most of the procedures that I do are in an outpatient setting, meaning the patients come in, they check into the hospital, they get some lab work drawn, they get the procedure done. It doesn't matter how small or how big the procedure, and they usually recover with me for a couple hours, anywhere from 2 to 4 hours, and they're discharged the same day. Again, I'm talking fibroids, prostate embolizations, kyphoplasties for spine procedures, you name it. And again, they are mostly outpatient-based procedures. And again, because it's quick recovery time, there are no open surgical repairs. We intervene on nearly all parts of the body. Me personally, I don't do anything in the brain, and obviously we don't do anything in the heart because that's for the cardiologist to perform. Everywhere else is fair game. And I really mean that. Anywhere from the carotid arteries down into any sort of arterial intervention from the neck down to quite literally the toe, any sort of venous intervention, any organ in the body, it is all fair game. So that's one of the reasons why interventional radiology is. Let's take a step back. The name in itself, when you hear about OB/GYN, when you hear about pediatrics, general surgery, neurosurgery, psychiatry, the name says it all, and everybody knows exactly what that physician is doing, what their job entails. But when you hear about an interventional radiologist, it's not exactly well known, and you kind of think to yourself, well, what does that really mean? Are you dealing with radiation, or what are you intervening on? Are you just reading x-rays? What does that mean? So our name doesn't exactly tell you what we're all about. And hey, hopefully after this talk, you'll be able to know that. And we closely work with all different specialties throughout the hospital. I truly mean that. I've had consults, and every day it's like this. So I have consults from OB/GYN, whether it be fibroid embolization or uterine artery embolization for bleeding, going to acute cholecystitis. I'm dealing with general surgeons, and I'm talking to neurosurgeons about a fractured vertebral body. Then I'm going to a pediatric or a pediatrician. I'm talking to them. So we quite literally deal with all different specialties throughout the hospital. And oftentimes we're the patient's last resort because the patient may not be a surgical candidate. They may have exhausted all their medical options. So where do they go? And this happens quite often. Every week we get a call, patient X, Y, or Z is crashing. They have this, and this that's going on with them. Can you do something? And physicians don't really know, hey, what can you do? But they're asking for that help. They're asking, do you have any options? And we, most of the time, try to do whatever we can for that patient because, again, it's their last resort. Let's take a quick break. Let me take a look at any questions before I go on to the next slide. I think I saw some questions that this slide should answer. Great questions. Thanks, guys. Yeah, there's some questions some people are asking, I believe, about how did I get here, basically? How long does it take to get into this field? What was my course? So how did I get here? Undergraduate. So after high school, obviously I went to college and I did my 4 years of college, and then I did some graduate work after that. I personally was debating between dental school and medical school. And I was in a pre-dental program in college, and I was going to go straight into a dental, it wasn't residency, but I guess dental program at that point, so long ago. But I just had a different calling. I knew it just wasn't for me. So I took some time doing some graduate work, really figured myself out, and I applied to medical school. And that's another 4 years. Internship is another year. You can do your internship in a couple of different things, whether it be general surgery, internal medicine, or a transitional year. Those are your pretty much top three internships. And I chose internal medicine. And then I did residency in diagnostic radiology, which is another 4 years after that. And then fellowship in interventional radiology, which is another year after that. So medical school, 4 years, intern year, 1 year, residency, 4 years, and then fellowship 1 year after that. Interventional radiology changed a little bit, actually. We are splitting from diagnostic radiology. So it's a little bit different. Interventional radiology now has its own residency program. Yes, you can still get there through diagnostic radiology, but now they're really trying to split away with their own residency program. And actually, that's one of the most competitive fields in medicine right now out of medical school. Next slide. Before we get to what is my typical day, let me try to start answering some of these questions. During therapy, fall under special. What drew you to this field? I will get there in a couple of slides. But one of the main things that did draw me to this field is what I mentioned earlier, past couple of slides, that we're dealing with every specialty, every specialty, and we're dealing from quite literally, I was going to say head to toe. Some stuff I do in the head, but neck to toe, we're dealing with it all. That was really intriguing to me. How many years do we, yep, just talked about that. What is the state-of-the-art technology in this career? State of the, you name it, you absolutely name it. So I do all my procedures under image guidance. So I will use CT scan, ultrasound, fluoroscopy, and MRI. I don't perform procedures with MRI. It can be done. So we are using cutting edge technology. I see exactly where my catheters, my wires, everything where it's going at all times. So it actually provides for a fairly safe procedure for the patients because of this cutting edge technology. What cases have been difficult to diagnose? So there have been very complex cases that come throughout interventional radiology throughout the week. A lot of patients who suffer from underlying cirrhosis. They have portal hypertension. We can talk about that. I think I have a case towards the end. Those can be quite challenging. A lot of patients for cancer therapy can be quite challenging with intraarterial therapy. Patients with chronic pain, we deal with these patients every single day. I'm doing procedures for patients with chronic pain, and that can be pretty challenging as well. All right, let's go back to the slides. What is my typical day? So getting to the hospital, I am going to our staff, and we're all just talking. What's our early morning huddle, basically? What does the day look like? What do we need to get this day moving? Who are the patients that are coming in? Are there any special supplies that I need for the procedure? And we're just kind of figuring things out for the day. And then it's patient rounding. So we are a clinical service. Luckily, we have a great nurse practitioner. She helps out with the rounding. So she'll see all the patients on the list. Our list can range anywhere from 5 to 20 patients. We're writing notes on patients every day, progress notes. We do detailed consult notes. We are a full clinical service. And then procedures. Throughout the day, I have my outpatient and inpatient procedures lined up. Usually the outpatient procedures are scheduled for the mornings, so we can get patients on their way after their recovery back home. But we do have emergent cases that come up often. And, unfortunately, just because of the emergent need, we do have to bump patients every once in a while. And then we do have inpatient cases as well that are scattered throughout the day. And throughout the whole day, throughout the whole week, we're fielding consults as well. We're getting phone calls all the time through our Epic, our electronic medical record. We're getting consults placed in there quite often, and we're just fielding them. We're talking to clinicians and we're saying, hey, what can we offer? Is there something we can offer? Or we'll give our 2 cents and say, I really think X, Y, or Z, or, this patient should go down this route. And I do have a I do have a clinic as well. So I do a day of clinic a week, and this basically seeing all different types of patients. I have referrals for, again, back pain, liver cirrhosis, cancer therapy, fibroids, knee pain. You name it, I'm seeing them in clinic. And then notes. I'm usually coming home. I'll, get back home, have some dinner, and then I'm writing notes. And those notes can take, maybe an hour towards the end of the day, just because the day's been pretty busy. And then I'll finish writing up and signing notes. What are my hours, by the way? It can be variable. It can range from, you name it, 8 to 5, sure. 7 to 6, sure. 6 to 10, sure. But generally, on average, I'm around 7:30 a.m. to 6 p.m. That's on average. I've had extremely late days just because cases have ran late. I've been on call, and we've had those emergent cases towards the end of the day, which, I stay longer for those. Yes, I've had to come back in the middle of the night for call cases as well. And it all depends on what type of service you run and what clinical setting you're in. If you're at a trauma center, your call may be busier. If you're not at a trauma center, I'm not. It's not as busy, but still there are GI bleeds throughout the hospital. There are other emergent and urgent cases that need to be dealt with off hours. Let's take a little break and go for some other questions. How is COVID affecting your workplace? So COVID completely shut everything down, like obviously everything else in the nation. All our outpatient procedures last year were pretty much back to almost normal. But last year, in following the initial months of the closure and the shutdown, COVID pretty much eradicated all outpatient procedures. And if it wasn't an emergent case, I shouldn't say emergent, if it wasn't a necessary case like cancer therapy, yes, we still wanted to do that for our outpatients. But if it was more of an elective case, we pushed them off, and patients were generally okay with it. Let's see. What are some common procedures, treatments that you perform in your day-to-day schedule? How long does it take to perform each treatment? Common procedures can range from, so the bread and butter for interventional radiology, bread and butter, the kind of lowest. You have your paracentesis, your thoracentesis. You're taking fluid out of somewhere. If it's from the abdomen or if it's from around the lung, you're doing biopsies, you're getting some tissue diagnosis. Those are kind of your bread and butter. A paracentesis or thoracentesis, sticking a needle into wherever you need to go, takes a couple of minutes. Draining the fluid can take a little bit. Biopsies, depending on what it is, if it's straightforward, easy, can take a couple of minutes. If it's a little bit more challenging, can take up to 20 minutes. And then your more complex procedures, you can have some chest tubes, your drains, you're putting into abscess drains. Then you can go into your, nephrostomies, putting tubes into the kidneys, tubes into the stomach, gastrostomies. What else? And then we can get on to the other cases that I'm going to show towards the end. Those would be more complex cases that we can talk about. What organs do you usually treat? I think we talked about this. We have another question about COVID. Yep. How did I decide to become a radiologist? So my third year of medical school, I met my mentor, and I still talk to him to this day, years and years later. And he gave a talk on radiology, and he mentioned something called interventional radiology. I had no clue what he's talking about. But I went to his office after hours, and I said, hey, I'm choosing between radiology and other specialties. I don't remember what they were at the time. And he said, well, after this day, you're going to be going into interventional radiology. I said, oh, sure, but I don't know what you're talking about. So he actually took me under his wing, and he was more administrative at the time. And he said, if you come up with cases, if you go to different services and you say, hey, do you have any cases that we can do as an interventional radiologist? He said, I will, let you scrub in with me and we can do these cases together. So from that day on, I was doing cases as a third-year med student, obviously under his supervision, and it just flourished from there. I still remember to this day, one of the very first cases, I think it was the second or third case that I did with him, was a renal biopsy on a pregnant woman, and did it with ultrasound guidance. And it did come back malignancy, but that actually completely altered her pregnancy and her course of care. That's pretty amazing to be, minimally invasive, get this tissue diagnosis, alter the care for the patient, which ultimately did make a quite big of a difference for her before childbirth. And it was done in, 15 minutes under ultrasound guidance, no complications, minimally invasive. She was up walking around 2 hours later. It's pretty remarkable. What other questions? What are some majors I should take to be a vascular interventional radiologist? How many years does it take in order to become VIR? So some of the majors, basically, did I read that right? Yeah, some of the majors. I did a bachelor's in science. I know people who have done, a various number of majors, whether it be music, English, history, and people kind of do whatever major it is. Yes, science major, science background will give you kind of that foundation for medicine once you get into medical school. But that doesn't stop you from, if you're an engineer, or if you're a music major, if you're a historian, whatever you may be, if you had a past career and you're switching over to medicine, it definitely should not stop you, and it will not stop you. You stay motivated, you keep moving forward, you will get your prerequisites done, and you can move on to medical school. And then from there, the doors are wide open. Let's go back to the slides. So do I take call? Yes. Interventional radiology call is vital to patients in the hospital and hospital workflow. It's absolutely vital. Again, people need our services around the clock, especially if it's a busy hospital, whether it be a hepatobiliary service, a transplant service, whether it's a trauma service. I've been in multiple institutions where, it's been all of the above, none of the above. So call really varies based upon what type of hospital setting you're in. Weekdays versus weekends. So weekdays, you usually do your general cases, inpatient, outpatients. Weekday call is not as busy. Usually patients can be, if it's like an acute GI bleed, usually you can transfuse the patient, and you can appropriately do whatever you need to, an embolization, angiography, whatever it need to be the next day. But for weekends, you can't have patients waiting a couple of days. So weekends tend to be a little bit busier. What do I find interesting about my job? Enter rant. Here we go. So this goes back to multiple slides before. What do I find interesting? And just checking the time, we're still good. Again, dealing with every single specialty, dealing with neurosurgery, dealing with OBGYN, surgery. I'm quite literally talking to all specialties all day long. And I'm helping out with management. And if it's an acute cholecystitis, let's give a typical patient coming in. We'll say it's a 70-year-old patient, 60-year-old patient coming to the emergency department, right upper quadrant pain, unable to eat, has some nausea, some vomiting, has had some low-grade fevers. They get the CT scan, the gallbladder looks a little inflamed. So what do you do from there? The patient may not be a surgical candidate, for whatever reason, whatever it may be. Well, you can place a cholecystostomy tube. And what is this? Essentially, it's a small little tube that goes through the skin, outside of the skin, straight through. I get through a little bit of piece of liver and then into the gallbladder. And I just let that gallbladder drain. Basically, 9 times out of, I shouldn't say that, but about 7 times out of 10, acute cholecystitis is caused by some sort of stone blocking the gallbladder from draining appropriately. So when it's blocked, you can see that the gallbladder is going to continuously get bigger and bigger, and then eventually some sort of bacteria can get in there and then cause acute cholecystitis. So by me placing a tube in there, I can allow this to drain out over the next several weeks, give it about a month and a half, and then eventually I can just take that tube right back out if need be, or they can go on to surgery and have that gallbladder removed. So that's one of the most satisfying things about interventional radiology. The other thing is, again, dealing with all parts of the body. Is I don't just say that I am a specialist in the liver, or I am a specialist in osteoarthritis, or I am a specialist in whatever, enter whatever. I get to say that I quite literally deal with the liver, the spleen, the kidneys, the bladder, the gallbladder, the knees, the back, all of this. And I get to provide patient care for all this, and it's all minimally invasive. And one of the most satisfying things for me, and I see this every single day, is if I'm performing a procedure, it may be a half an hour procedure, it may be a case that I've been in for 3-4 hours. And at the end of the case, the patient ends up with just a Band-Aid here, or a Band-Aid on their artery in the groin, or a Band-Aid on the wrist, because I go through a lot of radial access for arteries. And that's it. Patients go back to recovery. They have no idea what just happened inside their body. And all they look at is just a Band-Aid. And they say, well, did you really even do anything? There's no big incision. There's no, all this healing time, a month, they're down. Nope. That's one of the most satisfying things about my field. Let's see, going back to some questions. How often are minimally invasive procedures inapplicable to a patient? Depends. Everybody's clinically completely different. Whether it's, for example, let's talk about peripheral artery disease or peripheral vascular disease, PAD, PVD. Okay, a lot of the patients, if they're diabetics or they're smokers, they may have some claudication, or they're just old. They didn't, have a really good diet throughout the years. They have some claudication, they have maybe some rest pain, they're walking around for maybe, I don't know, a couple hundred yards, and they start saying, oh, my legs are hurting. Well, we can get in there and we can get into the artery supplying the leg and open them up, okay? But sometimes it just doesn't work. There's way too much calcium, there's way too much deposit in there, and at some point, they may just need a surgical bypass or an amputation. So, there are limits to endovascular procedures. That's why we work closely with our colleagues, our surgical colleagues. All right. What type of doctors do you work with? I think I've said that to Amrit. How do you balance your life and work? Yeah, work-life balance is always a plus and minus kind of when it comes to medicine. You go through all this training, and you've spent all this time, and you've been away from birthdays, you've been away from whatever it may be. And because you're motivated, you have an end goal, you want to be, at that kind of final mark in your life. So it's worth it. And then once you finally get to the job, work-life balance is a little bit easier. You're not, in that rigorous training. You're not constantly worried about that next test that you have to study for. So I just want to also stress that I've been there, I've done that. It is very stressful going through medical school, even pre-medicine, the whole route getting up to where I am right now. But at least me sitting here right now, it is 100% worth it. So I implore you, please keep with it, stay motivated. That's the one thing that I can suggest, is just don't give up. There will be a lot of ups and downs. Let me also say that there will absolutely be a lot of ups and downs throughout medicine and your medical training. But always, always, always have that end goal in mind. It will take you far in life. Do you ever disagree with the diagnosis your radiology tech comes up with versus what you come up with? So when you say diagnosis your radiology tech comes up with, are you quite literally referring to our tech who's taking the images, or are you referring to the diagnostic radiologist, doctor who's reading the images? Either or, everybody has differences of opinions, and we work together, and it's always in the best interest of the patient. We come up with the best and most appropriate diagnosis based upon the imaging for the patient. And when I read studies, I read them a little bit different than just a diagnostic radiologist who reads these studies, because I know what I'm looking at when it comes to flow dynamics in the portal venous system, in the veins or in the arteries. I know what's causing compression of those veins or those arteries that makes the imaging look like what they're looking like at that point. So I read things very differently when I'm interpreting these images. We talked about COVID again. What does an average day in this field look like? We kind of talked about that. Is this one of the more stressful ones? This field can be stressful, yes. I agree with that. It can be very stressful. And I say this all the time, is our patients that come into the Angiosuit are either, bread and butter outpatient kind of elective patients, or they are, they're crashing or they're getting close to that. So, my day can be just kind of steady, everything's good, routine. And then all of a sudden I get this call, patient's blood pressure is 60/30, heart rate's 150, maxed out in pressors, you got to do something. And then that's when kind of the adrenaline kicks in and you need to figure out what's going on. All right, let's go back to these slides. Advice for students. Okay, this is essentially what you are looking at right now, depending on where you are on this ladder. Pre-medical, high school, college, wherever you're on this ladder, you always feel like you're just looking up towards this dream, you're aspiring towards something, but you feel like the longer you're into this game, that the longer the ladder gets and the more you're trying to climb up this thing. Trust me. Life, you will continuously climb this ladder. The ladder doesn't shrink. And yes, you will eventually get closer to the top, but trust me, your motivations and your mindset and your aspirations, they will continue to grow as you grow. So don't worry about this never-ending ladder. It's enjoy the ride, enjoy the climb, okay? Stay focused. Just stay focused throughout. You will have a lot of, like I've said, ups and downs. I have been there. Everybody I know in medicine has been there, but we've all persevered just because we have that drive. We have that passion. We know where we want to be. Let's go back to a question. What gave me interest in interventional radiology? We talked about this. How competitive is VIR to get into? What interests me most about VIR? So talk about what interests me the most. It's pretty competitive at this point. Again, because we have split now into a separate residency than diagnostic radiology. So it's, I believe as of last year, it's one of the most competitive specialties in medicine now. In retrospect, is there anything you would have done differently to become an interventional radiologist? I personally wouldn't have done anything different. I stayed motivated. I knew what my end goal was throughout this whole experience. I knew what I wanted to do. I made a lot of connections. Medicine and life in general, it's about who you know and your personality. Your personality goes a long way. Yes, let's take a step back from this. Is when I talk to medical students and I talk to pre-med students, everybody, their scores, yes, they're all averaged around right here. Yes, some are up here. Yes, some are down here. Everybody's research experience is kind of averaged around here. Yes, there's some up here. Yes, there's some down here. Volunteer hours, all averaged around here. In that same range. So what really sets you apart from other people? Number one, your personality, okay? And what I mean by that is, yes, when you interview, they want to see your personality, but also how have you interacted with, in your day-to-day, your attendings that you've worked with, your research mentors that you've worked with. And the other thing, speaking of mentors, as I can't stress this enough, is find a mentor, especially in the field that you are trying to go into. Get close to somebody, pick their brain, use their knowledge that they have, worked hard over the last 10, 20, 30 years, however long it may be. Absorb that knowledge from there. Get to know them so well that when they write you a letter of recommendation, when it comes time to, if you're applying to whatever school, it just flows for them. They can write it easily. It's not a generic letter. That goes a long way. If I were in my clinical rotations and I'm applying to residency and I just go up to a random attending, random doctor, and I say, hey, do you mind writing me a letter of recommendation? They don't really know me. They say sure because it's awkward. They don't want to say no. So they just churn out this little paragraph saying, so-and-so did great. It was a great student, have good things to say, but that's not going to go anywhere. So when you really get to know people, know physicians, know your mentors, they can really go to town for you. They make phone calls. That goes a long way. So that's my one piece of advice that I give all pre-med medical students. Are there any DOs in radiology? Yeah, I know a lot of DOs in radiology. So if anybody doesn't know, there's MD, DO. It's the same. Everybody, is on the same page once you get into residency, even med school. I know a lot. I actually had 3 in my program when I was in residency. All right, let's go back to slides. All right, let's look at some imaging. And time-wise, we're still doing okay. Every interventional radiologist needs to be proficient in medical imaging, okay? So you can't be an interventional radiologist without knowing imaging. And the reason being is because you are using imaging to literally perform every single procedure that you do. You need to know where things are on the X-ray or the fluoroscopy machine, in the Angiosuit, on CT. You need to know what vessels you're looking at. When I'm doing an angiogram, what vessel has my catheter gone into? What am I shooting right now? If I were to coil embolize this vessel, what would that mean down the line? Is this going to cause ischemia? Am I able to coil this off? So you really need to be very adept at reading imaging. So let's go to something basic. This is a KUB. This is basically just an X-ray of the abdomen, okay? So if anybody hasn't seen what a KUB looks like, it's pretty much what I just said. It goes from the bottom of the lungs all the way down into the pelvis, and it's usually taken for checking bowel gas pattern to see if somebody's obstructed. That's usually what this is ordered for. What organ should typically be seen on a KUB? If anybody wants to start blurting out things right now, I can't hear you, but feel free. Next this is the liver. So big red arrow, this is pointing to liver. So that's number one. Number two, if anybody has any guesses, that's the spleen. Okay. And then number 3 and 4 go together. Those are your kidneys. It's tough to see, but can you make out that this is a kidney shadow right here? Hopefully you guys can see my arrow. And then can you make out that this kind of bowel is being pushed away? Well, that's more of the stomach issue, but at least it's allowing you to see the silhouette of the kidney. And then the last one, look at the bladder. I don't know if you guys noticed that, but now you can see the contour of the bladder here. Okay, so very basic KUB, but you need to know these things. And just off of this, I can tell you that this is a kid. This is not an adult. How do I know that? Because I'm looking at the bones here. This epiphysis has not fused yet. This apophysis right here has not fused yet. So this is a kid, probably, I don't know, 12 years old. There's something going on the hip right here. If anybody wants to chime in and figure out what this is, feel free. That's a little bonus question. And then this is some bowel. This is, again, what I was talking about. That's usually what a KUB is ordered for, is looking at bowel. This is large bowel. This is small bowel. How do I know that? I'm seeing thousands of these. Or you can say, well, this is a haustral fold, and this does not go all the way around the bowel. This stops halfway in between. That's how I know it's a large bowel. And this is a plica circularis, this little line right here. This does go all the way around the bowel, and it does go around small bowel. All right, before we get to IR case conference, by the way, and I'm going to go back to questions now, this is a pretty much typical Angiosuit. This is what I work with every single day. This is lead right here. This protects me here. These are my fluoroscopy pedals right here. I step on this pedal to get live imaging. I step on this pedal, this one right here, to get me a run when I inject contrast. This is the X-ray tube, shoots up like this. This is the C-arm that can spin all the way around and actually end up looking like a CT if I need to. Patient lays down here. All my images get posted right here. All right, let's go back to questions. Let's see. How many hours do IRs work? We talked about that. What are the most common procedures? Talked about that. Do you see common age range in patients? Ooh. Common age range. So I see the whole gamut. I don't do anything personally in pediatrics. I have done pediatric cases before. I don't deal with peds patients, but I see patients ranging from essentially 15, 16 years old onto my oldest patient's probably been 101. So I quite literally see the whole gamut of age range. What type of tools would an IR interventional surgeon use on the daily? Types of tools. So wires and catheters, those are the main things. If I'm getting access into the femoral artery or into the radial artery or into the femoral vein, wherever I'm getting access into, I'm getting a catheter and a wire. That is step one. Get your wire down first and then get the catheter to track along it afterwards. Then eventually I can take the wire out and now I have a catheter into the vessel. I can do whatever I need to from there, whether it's inject contrast for an angiogram or to embolize something with beads, a coil, whatever it may be. What is your opinion the most enjoyable part of being a VIR? Again, working with all specialties and then providing relief or providing care for patients that are they've been suffering for a long time and they're not surgical candidates. You know, chronic pain. Let's go with chronic pain. For example, patients come in with back pain that they've dealt with for years and years and years, and surgery, you know, they can't touch them. Neurosurgery doesn't want to do any intervention. Orthopedic doesn't want to do any intervention, too old to do anything. Medical management, well, they may be taking opioids. Now they're hooked to Norco and, you know, they're constipated because of it. And it's just not doing much anymore because they become tolerant. Well, then they somehow get to my clinic or I see them inpatient and I say, let me talk about your options. And then if it's a fracture that's been going on for a long time, I can put a needle into the vertebral body and just cement it shut. The fracture is gone. I can put steroid injections into the epidural space to cause the nerves to basically de-escalate and the pain to go away. And afterwards, I mean, patients are very appreciative because their pain is, you know, pretty much gone at that point. And it's all done through a little tiny pinhole, through a needle. What is your favorite non-invasive procedure? Favorite, one of my, oh man, let me just go. Okay, there we go. One of my favorite aspects of IR, one of the favorite procedures that I do personally, anything portal venous, anything with portal hypertension, whether it be at TIPS or embolization of varices. If anybody doesn't know what this is in cirrhosis, liver cirrhosis, from whatever reason, patient is cirrhotic, maybe from longstanding drinking, hepatitis C. These days, it's actually NASH or non-alcoholic steatohepatitis, basically fatty liver. And that can cause cirrhosis, and that's actually a leading cause of cirrhosis these days. And it's going to be a leading cause of liver transplant coming up soon. And anything portal hypertension. So this cirrhotic liver is so fibrotic that blood cannot flow through there naturally, and it can't filter through there as it should. So the blood ends up reversing, going the other way, and it can cause a lot of these dilated veins, especially in the chest, around the esophagus. It can cause some bleeding episodes. It can cause swelling in the belly. So anything portal venous, I really enjoy. And I've been doing a lot more procedures on knee osteoarthritis. I'll talk about that. So patients don't have to basically do physical therapy long-term, taking ibuprofen all the time, and then thinking that their only option is to go for a knee replacement. Well, I'm in the middle. I can, instead of taking this medication, instead of going to surgery, I can do something right in the middle, and I'll show you in case conference coming up here pretty soon what that is. Where do you see the future of IR going? I mean, the sky's the limit in IR. We're doing things like we are taking stones out of the gallbladder. We are ablating tissue that's causing stricturing of the biliary system with lasers. It's the sky's the limit, honestly. Let's go back to case conference. Yes, this is my lead. I have Paisley lead. It always brings a smile to people's face when patients on the table nervous and they see this. So iliac disease. So this is what I mean by an angiogram. I have access to the patient's artery, okay? So I have one axis here, and you can see this catheter going up, and you can see nicely this other catheter going up the other side. And see this area of narrowing right here, okay? The patient is complaining of left leg pain. So this is the right side of the patient. This is the left side. And this is the aorta. This is the big artery in the abdomen that's pretty much supplying blood to the rest of the body. So there's this narrowing that's occurred right here. And this patient's had pain with walking, ulcers on their leg that are not healing well. And I said, you know, let's see what's going on. Did the angiogram, saw this area that was very narrowed, and then placed another stent. There were stents in here before, just weren't working too well. Placed another stent, ballooned it open, pretty much symptoms resolved in the next couple of weeks. This is an outpatient procedure. Patient stayed with me 4 hours afterwards, home afterwards, saw in clinic a week later, 2 weeks later, did well, symptoms resolved. Epidural steroid injections. And, you know, these cases that I'm showing right now, this is just the tip of the iceberg. If I could, I would go on for hours talking about different cases that I could do. But this is just, I want to give a broad generalization of different types of cases that I can perform. This is an MRI of the spine, the lumbar spine. This is the sacrum here. And these are the vertebral bodies of the lumbar spine. And you can see this disc bulge right here. These are the discs, 1, 2, right here. And this one is bulging back a little bit. And then this kind of ligament is hypertrophied on this side. And it's causing some narrowing over here. So it's a little bit of spinal canal stenosis, okay? And, you know, this is somebody that doesn't want to get surgery. Back surgery is no joke. It's an open procedure where they have to, in this case, they may do a laminectomy. It's up to the neurosurgeon how they would handle this. This patient did not want to go through back surgery. So essentially I get a little tiny needle and I get it to this space. If you can see the tip of the needle, which is right here, and that is equivalent to this area on the black line on this MRI, and that's the epidural space. And I injected some steroids in there. This procedure takes about 10 minutes to do. I do it under a live fluoroscopy, live x-ray, and its symptomatic relief is actually pretty instantaneous. And it can last anywhere from some patients, say a couple of months, some people go a couple of years actually with this relief. Deep venous thrombosis, so DVTs. A lot of patients, especially during COVID, have been developing a lot of DVTs, a lot of lower extremity swelling because they've just been inactive. They're sitting at home, sitting on their computers all day long. And this is a catheter that I have right here. I had accessed the vein. So this is all the venous system. This is not arteries anymore, okay? So this patient is prone to having deep venous thromboses because this is an IVC filter. And this is something that's supposed to catch the blood clots when they fly off from the leg through the big IVC, and it's supposed to stop them from going to the lungs to cause a pulmonary embolus. So I injected some contrast dye, and you can see there is no opacification of this vein, this portion of the vein, and then up into the IVC at all. And you can see some contrast trying to go from these kind of lumbar veins, trying to make it back up into the heart, but it's taken forever. So essentially what I did is I put a vacuum cleaner in here. That's quite literally what it is for the veins. And it's a big vacuum cleaner, and I sucked out all this clot. Sucked it all out. After about 30 minutes, this is what it looks like now. Wide open, injected the contrast. It's going straight up through the IVC back to the heart. You can see a little filling defect right here. That's a little bit of thrombus that the filter has caught. And this is exactly what the filter is supposed to do. So I took out the filter right after. Patient has a clear vena cava. This is, it can be an outpatient procedure. I've done it outpatient, but in this single session, patient recovers overnight. And then this patient went home the next day. Liver cancer. So for example, I mean, we deal with cancer all the time. For example, in the liver, you can see this mass right here. This is a CT scan, contrast enhanced. How do I know that? Because this is the aorta right here, and it's nice and bright. So you can see this mass is not enhancing as nicely as the background liver. This is on the coronal section right here. And well, what can we do? You know, other ways of dealing with this, you can have systemic chemotherapy. You can do partial surgical resection of this. Patient may not be a candidate for surgery, doesn't want to go through systemic chemo and the systemic side effects. What can I do? Well, I can get a probe under ultrasound guidance and CT guidance, basically stick a probe, a microwave probe into this tumor. In this case, I did 2 of them and ablated it. It's quite literally turning on a microwave, heats it up really hot and destroys the cancerous cells. Another way of handling this is not the exact same patient, but this is a similar case. This is an angiogram of the liver. This is a catheter that I have into the celiac artery, and you can see the common hepatic artery here, the proper hepatic artery here, gastroduodenal artery, and then in the right hepatic lobe, you can see this abnormally enhancing, arterially enhancing large mass. So what did I do for this patient? I parked the catheter all the way up here, and I injected radiation into this patient's tumor. So yes, we can do radiation, intraarterial, and we can do intraarterial chemotherapy as well. Let's go back to some questions. When treating tumors, do the VRA procedures only affect malignant tumors that are in the blood vessels, or do the procedures also treat cancer in organs other than the heart? Oh, that's a perfect question after I said this slide. So yeah, we treat patients, I mean, cancer in the kidneys and the liver, I don't know, you name it, in the lung. I can do cryoablation where I not heat up the tumor really hot, but I make it really cold and can destroy the tumor as well. So I can do that in the lung as well, can do it in the bones, you name it. Do you have any experience with misdiagnosis? And if so, when? I mean, misdiagnoses happen. And it's sometimes if it's easy, you see what the imaging shows and it's all looking, bread and butter, sure. But sometimes, and that's what medicine is. Sometimes there are zebras and you are not 100% sure what it is, but you make your best educated guess on what it is. And then you ask your colleagues, you say, hey, what do you think about this? Yeah, of course that happens. That's any field. Which systems or organs do you use in order to precisely practice IR? How's VIR different from other radiology specialists? Why do you pick this one? We've talked about that. Some of the main procedures, we've talked about that. Day in the career, we talked about that. How hard is it to get into radiology? We talked a little bit about that. What is your most risky operation? Oh gosh, I mean, um, patients that are, I mean, crashing, you know that you're sometimes their last resort, and you know that you need to find that bleed wherever it is, and you need to handle it, and you need to take care of it. Otherwise, you know, medically, they may not be able to be managed. They're obviously not going to surgery because they're so end stage. So if somebody's crashing and you know that it's from hemorrhagic shock, meaning they're bleeding somewhere in the body, whether it be in the portal venous system, you have to do a TIPS to shunt out that blood, or if it's a bleed in the pelvis or in the liver, wherever it may be, that pressure's on. Okay. Intractable pain, let's talk about that. So this is a CT scan, and patients having intractable pain, whether it's from, in this case, you know, it could be chronic pancreatitis, it could be malignancy, whatever it may be, but they're having intractable abdominal pain. So what I can offer is I can get a needle, and this is the back of the patient, this is the front of the patient, this is the liver here. So you can see my needle skirting by the kidney right here, and this is the aorta, this is the celiac artery, and I parked it right here. I got a needle on the other side as well. This is the other kidney. This is the aorta again, celiac artery here, and I parked the needle on the other side, and I injected some material. So what did I inject? I injected alcohol. So this is a celiac ganglion block. So there's a celiac plexus there that's giving the pain receptors or the pain from that abdominal discomfort, and it's going up to the brain saying, ow, it's hurting, I'm hurting. And so what I do is I ablate these veins, or sorry, I ablate these nerves with alcohol. And that's what I did here. Uterine fibroids. So you can see this is a sagittal view on the MRI. This is the spine, kind of what we saw before. This is the spine, what we saw before. This is the sacrum. This is the coccyx back here. This is the bladder right here. This is the bladder right here. You can kind of see when a woman is pregnant why you have to go to the bathroom all the time. Because imagine if this were a pregnancy and it's causing compression of the bladder. Well, in this case, the patient has a large fibroid. It's also causing compression of the bladder. So one of the symptoms of large fibroids could be frequency for urination. Well, what if a patient doesn't want to go to surgery and get a myomectomy or an abdominal hysterectomy? What if they don't want to do that? Well, what can I offer? And this is a pre-embolization and a 6-month follow-up. You can see that there's no more pressure right here on the bladder. You can see this large fibroid has now shrunk down to this size. And well, what did I do? These are uterine fibroids. So basically got a catheter into the arteries and the aorta and did an angiogram. And these are the uterine arteries. This is completely abnormal. These are massive uterine arteries. And I injected beads and I embolized the fibroids. And this is immediately post-embolization. You don't see those arteries anymore. They're completely gone because I've taken care of them. You can see a hint of one right here, but compare this size to what it looked like before. And this is uterine artery fibroid embolization. Trauma, deal with trauma quite often. This is a kidney right here. You can see that these arteries are very abnormal because they're clamped down. This patient was on pressors that were elevating the patient's blood pressure via pharmacomechanics. And this is a bleed. Injected some contrast dye into the arteries, into the renal artery here, and then you can see this bleed just pouring out into the abdomen. And well, what did I do? This is a coil pack right here. So if you see these coils, you don't see the bleed anymore. And now you see this just little wedge defect right here, where that portion of the kidney is not being perfused anymore. That's okay because I handled the bleed. And what would have been the alternative for this? The patient would have gone to surgery, either gotten a heminephrectomy or a nephrectomy, meaning they would have taken off half the kidney or taken out this whole kidney to control the bleed. Well, what did I do? I probably took out about 15% of the kidney with these coils. Patient recovered for 2 hours afterwards, discharged the next day. Knee osteoarthritis. This is one of my favorite procedures. This is a knee x-ray. You can see the medial compartment of the knee. There's bone on bone. We initially thought that knee osteoarthritis and the pain from it is basically the mechanics of causing grinding of those bones together. Well, there's also a big inflammatory component of it as well. So what did I do is I basically got a little tiny microcatheter into the artery that's supplying this aspect of the knee. This is a contrast dye into the artery here. This is the popliteal artery. And this is now another image of my microcatheter, which is parked around right here. And now I've blown up the image. And this is the aspect of the knee that's causing all that inflammation and that pain. So if you look at these little blotchy black areas right here, essentially I provided a little bit of embolic, not too much. And on my post-embolization angiogram, you don't see those blotchy areas anymore. This patient's pain after 2 months completely resolved. He's not going to surgery. And if the patient does want to get an arthroplasty eventually, no problem, because I did not knock off any of the arterial supply to the knee. All I did is I embolized that hyperemia, or that blush of the synovium. So minimally invasive procedure for knee pain. Kyphoplasty, these are patients that have fractured the spine, and it's causing just terrible pain. You can see this vertebral body is pretty much what I like to say, like a pancake. It's very compressed anteriorly. This is what happens quite commonly because the pressure of the spine collapses down the anterior portion of the vertebral body. Well, the patient's in a lot of pain, so what can I do is I basically get needles into the spine and look at how many different levels. I did 4 levels on this patient. And injected cement. This is cement that solidifies in 4 minutes. Patients, their pain usually starts resolving in about a week, and they're back to normal function, usually in a typical case, in about a week and a half. Also, if this patient had metastatic disease, meaning there's actually metastases scattered throughout the spine, I can actually insert these probes into there and ablate them.
Did he freeze?
I think he got disconnected. We'll just give it a moment before he reconnects. Yep, just give it a couple moments. We're gonna try to see if he can get reconnected. Hey,
I think
it
it
looks
froze.
good. Yeah, I think it kicked you out for a second. But yeah, you can continue.
No, so that was it. I don't know what you guys saw at the end, but basically I was, I don't know if it's still sharing my screen.
Oh,
Let's see. Okay. Yeah, no, that was pretty much it. Essentially, you guys, contact me anytime. I'm happy to help. My, Instagram's handle is right here. And it's stay motivated, stay positive. That's my one thing that I can say is this journey continues for a while. And there are a lot of ups and downs, but there's so many ups. You will be so appreciative on the other end, and you will enjoy it. So again, stay motivated. And again, any questions, let me know.
all right. Thank you so much for your time today and for giving us an amazing talk and all those cases that you shared with us. That was really interesting for sure. I actually didn't really know that much about this profession that you're in. And I definitely am interested now. But yeah, so thank you so much for that. And
No
for
problem.
everyone who is still watching, we're gonna send out the link to the Google Forms like right now, and it'll be open until 8:30 p.m. So please fill that out to get your shadowing hour for today. But yeah, thank you so much.
No problem. Thanks, guys. Really appreciate it.